are going to talk about aortic valve stenosis. So, general overview, definition, what is aortic valve stenosis, etiology, pathophysiology, clinical presentation, diagnosis with classification and staging, treatment, and complications. So first of all, the heart has four chambers: the right atrium and the right ventricle separated by tricuspid valve, left atrium and left ventricle separated by mitral valve. And we have the pulmonary valve separating right ventricle from the pulmonary artery, and the aortic valve, which is separating the left ventricle from the aorta. So the blood comes desoxygenated from inferior vena cava and superior vena cava, and it comes to the right atrium at first, where it passes to the right ventricle through the tricuspid valve, and then it goes to the pulmonary artery through the pulmonary valve, and it passes to the lungs where it gets oxygenated, and it comes back to the heart through the pulmonary veins into the left atrium, and from the left atrium it passes through the mitral valve into the left ventricle, and from the left ventricle it goes through the aortic valve into the aorta, and from the aorta it passes to the organs and tissues of the body. Aortic stenosis means narrowing of aortic valve, and as a result of it, the outflow of blood from the left ventricle into the aorta is obstructed during systole, and this leads to chronic and progressive excessive load on the left ventricle and potentially development of left ventricular failure. Etiology: aortic valve stenosis is mostly caused by sclerosis, which is calcification and fibrosis of the valve, which is physiological happening, and it's most common especially for patients who are at older age, between 75 and 85 of age. While for the younger patients, we have bicuspid aortic valve as the most common etiology. Is a congenital pathology which predisposes the valve to dystrophic calcification and degeneration, and the patients present with symptoms of aortic stenosis earlier than in regular aortic valve calcification. Here we have a picture showing the difference between normal and bicuspid aortic valve on the left. And we have also another cause, which is rheumatic fever, which remains significant cause of aortic stenosis in lower income countries. Here on the right side you have a transthoracic echocardiography picture of aortic valve, showing the difference between a normal valve and aortic sclerosis. We can see here during aortic stenosis the valve's leaflets, they look thicker and they look more calcified than the normal valve. Now, pathophysiology. So what happens during aortic stenosis, due to this narrowed opening of the aortic valve during systole, as I said before, it leads to obstruction of blood flow into the left ventricle, and eventually it will lead to increase in the left ventricular pressure, and it will lead to left ventricular hypertrophy. This hypertrophy is called concentric because of increase in pressure. We have another type of hypertrophy, which is eccentric because of increase in volume. Here we have concentric hypertrophy. Due to that, there will be increase in the left ventricular oxygen demand and impaired ventricular filling during diastole. Eventually, it will lead to left heart failure. And there will be also decrease in the coronary flow because there will be increase in the left ventricular mass, and there will be increase in oxygen demand and decreased coronary flow. So, due to decreased coronary flow reserve, the patient will be presenting with myocardial ischemia symptoms. Also, the heart will have a propensity for ventricular arrhythmias due to this myocardial ischemia and fibrosis. Initially, the cardiac output can be maintained within this condition, but later there will be increase in the sensibility of the left ventricle, which will reduce the cardiac output. And this may cause backflow of blood into the pulmonary veins and the capillaries, and there will be a higher afterload or higher pulmonic pressure, which eventually it may lead to right-sided heart failure. Now the clinical presentation. The patients usually they may remain asymptomatic for years, and usually they will start to develop symptoms when the disease progresses to severe aortic stenosis. The symptoms may be presenting at rest or on exertion, or both of them. There will be symptoms of dyspnea, of angina, dizziness, and syncope. Additional signs specific to infants will include wheezing and difficulty of feeding. On physical exams, we will have a small blood pressure amplitude, decreased pulse pressure, which is the difference between diastolic and systolic blood pressure, weak and delayed distal pulse, and on auscultation, we will have a harsh crescendo, decrescendo murmur. It's called also diamond-shaped murmur, and it's late systolic ejection murmur, which radiates bilaterally to the carotids, but it also depends. Like sometimes it doesn't radiate. It depends also on the severity of aortic stenosis, and it's best heard at the right second intercostal space. Now, for the classification of aortic stenosis is basically made after obtaining the measurements using transthoracic echocardiography. So for mild till moderate aortic stenosis, we have two stages, stage A and stage B. Stage A is at risk of developing aortic stenosis, so basically it's aortic sclerosis. We use three things to determine the classification or to classify aortic valve stenosis. We have aortic valve area, transaortic velocity, and the mean aortic gradient. So, if the aortic valve area is between 3 till 4, transaortic velocity is less than 2 meters per second, and the mean aortic gradient is less than 10 millimeter mercury, is stage A. It's called progressive aortic stenosis if we have the following. If the aortic valve area is between 1.5 till 2.9, it's mild. And if it's between 1 and 1.4, it's moderate. Transaortic velocity, if it's between 2 till 2.9, it's mild. If it's between 3 till 3.9, it's moderate. While for the gradients, between 9 and between 10 and approximately 20, let's just say, it's mild. If it's between 20 and 39, it's moderate. For severe aortic stenosis, the aortic valve area is less than 1. Transaortic velocity is more than 4, and the mean aortic gradient is more than 4C. It has three stages. We have stage C1, C2, and D. Stage C1 is asymptomatic severe, but still with normal ejection fraction. Stage C2, asymptomatic severe aortic stenosis with left ventricular ejection fraction less than 50%, and stage D is symptomatic aortic stenosis. Now for diagnosis, transthoracic echocardiography is the first modality of diagnosis. We can use transesophageal echocardiography if the images that we obtained were not so clear. Using transthoracic echocardiography, lab tests like NT-proBNP level can help us to detect heart failure, ECG to detect signs of left ventricular hypertrophy or the presence of arrhythmias, X-ray to detect presence of pulmonary edema if we suspect it. We can use additional tests like exercise stress testing or low-dose dobutamine stress tests if the patient cannot do physical exercise. Stress testing, so it's indicated to detect if the patient has symptoms during exercise. Cardiac catheterization and coronary angiography can be used. Coronary angiography for detection of myocardial ischemia or coronary ischemia, and advanced imaging like cardiac MR or cardiac CT to detect the presence of fibrosis and inflammatory conditions affecting the heart. Now, talking about the treatment, basically for symptomatic and or severe aortic stenosis patients, surgery is indicated, either aortic valve replacement or repair. Uh, Surgical aortic valve replacement, of course, is more complicated than aortic valve repair, and it depends also on each case of the patient. Uh, Asymptomatic or mild to moderate aortic stenosis, medical management with monitoring will be indicated, including echocardiographic monitoring. So we have to treat comorbidities, treating heart failure by giving beta blockers, ACE inhibitors, ARNI, uh, empagliflozin or dapagliflozin, MRI or diuretics as well can be used in case of presence of pulmonary edema. Treating hypertension if it's present, diabetes, monitoring hemodynamics while waiting for the surgery, because for severe aortic stenosis, usually it's complicated as well by acute heart failure, acute decompensated heart failure, and cardiogenic shock. Can be treated with inotropic treatments, it depends on each case. Diuretics if presence of edema, treating arrhythmias if they are present, like atrial fibrillation with rapid ventricular response. We can treat it with beta blockers to control the heart rate. We can add anti-arrhythmic drugs or cardioversion if the patient is stable. We consider bridging procedures if the patient cannot, for example, if the patient is waiting for surgery, if we cannot maintain the patient only by medications, we can use mechanical circulatory support. We can use bridging procedure, surgical procedure like percutaneous balloon valvuloplasty. We have to keep in mind that also after aortic valve replacement, we have to give antithrombotic therapy, and the aortic valve replacements, as I said before, it depends on each case of the patient because we have to um, calculate basically the bleeding risk compared with the thrombotic risk or the risk of developing thromboembolism. Because we have two types of valves. We have the bioprosthetic valve replacements and the mechanical aortic valve replacements. Usually after the mechanical aortic valve replacement surgery, the patient will need anticoagulation therapy for life, while for the bioprosthetic valve, it's basically indicated after 3 to 6 months after the surgery. For the complications of aortic valve replacements, it includes vascular complications, thromboembolism and stroke, major bleeding, renal failure, arrhythmias like atrioventricular block, and atrial fibrillation. The development of aortic regurgitation, which is called paravalvular leaks or paravalvular regurgitation. Infections like endocarditis is also very common, especially with bioprosthetic valve replacements. And that's all for today. I hope it was useful. Thank you.